Good morning, good afternoon, good evening, all. My name is Joe Ali. I'm our seminar committee chair for the Berman Institute of Bioethics. I have the pleasure of introducing not only our seminar series today, but also our invited speaker, which I'll do in a moment. But let me first begin by just welcoming everybody to our biweekly seminar. As we usually do, have about 40 or 45 minutes of presentation or so, followed by some discussion. And we invite anyone who'd like to post any comments or questions to do so using the Q&A or chat functions. And we'll monitor that and raise them for conversation during the discussion. We also have opportunity for people to raise their hand using the hand raise function if you'd like to speak, and we can facilitate that. So please feel free to do that. And Sridhar, our speaker today, may invite you to do so at various points during his presentation as well. So please stay tuned for that. I think that's it for now. I'm just going to transition right into introducing our speaker. So today's speaker is Dr. Sridhar Venkatapuram, who's an associate professor of global health and philosophy at King's College in London. He's also deputy director of King's College's Global Health Institute. Sridhar, among other things, is at the forefront of public and global health ethics for many years. In the late 1990s, he was one of the first researchers at Human Rights Watch to focus directly on health-related human rights violations in HIV/AIDS, specifically in India. He's known very well for his work on health justice and philosophy, and for engaging with various organizations in public and global health practitioners as well on the work that's being done currently to amplify ethical reasoning in public and global health education, research, and practice. Sridhar, I think we met a few different instances, once at WHO when you were doing a stint there, and also around the World Congress in Bioethics in India. It's been a pleasure, as always, to have opportunities to speak with you and to hear about your latest work. Obviously been involved in so many other important initiatives with WHO and the NHS in the UK and others, which I won't recite now, but we'll just thank you again for joining us and offering to provide a seminar today on older people and the demands of global social justice. So with that, I'll just hand over to you, Sridhar.
Thank you very much, Professor Ali. So let me begin by first saying thank you very much to the organizing committee for inviting me to speak. It's both a privilege and a real pleasure to be able to speak to this particular audience and to some of my colleagues who I haven't seen in a long time. So I want to firstly thank that committee and other people in the Berman Institute and all of you for taking some time out to come hear me today. I also want to sort of give you a basic outline of what I'm going to do in the next 30 to 45 minutes. So my aim is to speak about justice for older people. And I want to do this by giving you first just a quick slideshow. If I was in person, I would sort of have these slides behind me, but because I'm doing this online, I'd like to be able to get away with showing you the slides first and then speaking to you for the remainder of the talk, and it'll only just be very quick. And then I'd like to talk to you about three aspects of it, of the talk. One is that I'd like to talk to you about using a standard of justice in order to conceptualize well-being for older people, and then point to two different kinds of claims that might arise from that kind of standard of justice, particularly regarding inequalities among older people. And then the second part is about thinking about social and global justice claims. So those will be three parts, and then we'll do a question and answer session. So if that is okay, I'm going to start by showing you some slides, just sort of 5 slides. And these are slides about facts. And I ask you to sort of take them as sort of validated and sort of from trustworthy sources. So I'm going to share my screen. And let's see. and PowerPoint. So can you see my screen?
Not yet.
Okay.
Here it comes.
Do you see it?
Yes, we see it, although it's not yet in presenter mode. So if you would
Okay.
like to switch to that, you'll...
Let me try lots of different things now. My apologies. We tested this out. Okay. Now, do you see anything?
Not yet. There we go.
Yeah.
Yeah.
Okay. My apologies for that.
No worries.
So there's just, as I said, 5 quick slides. So the first slide is from statista.com, and I've double checked with the CDC website, and this aligns fairly closely to it. So this is the mortality from COVID, official mortality from COVID in the United States. And it's basically showing that the majority of deaths from COVID have been among people that are 50 and over, and largest number of deaths are in people who are 65 and over. The second slide is from a talk that David Williams from Harvard gave, and all this slide shows is very important, which I've been looking for many years now, which is that it shows a sort of all-risk mortality based on socioeconomic class or income. And here what you see is that on the right-hand side, if you take all the people who earn $115,000 annually as the sort of standard, then you see that every sort of income group below that has a multiple chance of all-cause mortality. So the people who are making less than 25,000 per year are 3 times more likely to die than the people at the top. But the important thing is to understand that there is a sort of a fine gradient across income levels. The third slide is again from David Williams, which shows that this is life expectancy for someone who's age 25. And what it shows is that if you have 2 different individuals, and one is white and one is black, 2 individuals with the same kind of college education, if you are black, you are still likely to die younger, so a space of at least 5 years younger than someone who's white and has a college education. But the other thing that's also important to see is that you are, if you are fully sort of have an undergraduate degree, you have a lower life expectancy than someone who has got no college degree and who is white. The fourth slide that I want to show you is in terms of aging. This is a picture, global picture of projections of people who are going to be age 60 and over. And as you can see, is that there is a remarkable increase in the number of people in the world who are going to be living older than 60, but the majority of those people will be living in developing countries over the next sort of 2-3 decades. And the last slide, or there's 2 more slides, my apologies, is that this is a slide for what is called hand grip strength. And so it's a measure that's used for vitality. So if you can squeeze your hand and the amount of pressure that you exert over your hand with your hand in this instrument, then will show you some sort of indicator. And this is from 5-year age groups in across 36 countries. And the 5-year age groups on these layers. And what I wanted to just focus on is see the distribution that the oldest group, for example, 90 plus, if you think of that as the light lilac here, is that some people who are 90 plus have a better, stronger hand grip than the majority of some other much younger, potentially 20 to 35 years younger than they are. So this is a great indicator of the inequality among older people regarding their vitality, but it could also be other ways as well. And then this is just a heuristic diagram that's put out by the UCL folks who work a lot on social inequalities in health. And it's this concept of a life course approach, where if you start from prenatal until retirement, that there are a number of places in which you have significant influence over someone's life course. And then there's different kinds of influences that are happening over the life course. And the health at the old age is actually a cumulative effect of what's happening over the entire life course. So that's really it for the slides. And it's really meant to give you some empirical background or grounding from which I have been developing some of the ethical arguments here that I want to present to you, and some of the ways in which I try to make sure that my ethical arguments are informed by some of the science and demographic data that's coming out, and that's sort of give us a picture of what's going on. So to bring sort of those sort of facts to relevance to what I want to talk about, the initial idea about this concept of justice for older people came from a significant number of instances where we see something as being unfair and unjust in regard to older people. Many of you who are physicians or who are other care workers dealing with older people already know that there is some significant ethical challenges or dilemmas and discussions regarding providing care for older people, either on the side of neglect, where older people require care that they cannot get, or there's also been conversations about the problem of providing futile care, and how do we deal with systems and values and different kinds of situations where care is being provided when it may not be the best thing for the individual or what the individual wants. But there are some other kinds of non-medical domains in which there's also a great amount of unfairness or injustice, or at least seemingly appears. So for example, in most demographic surveys, including UN statistics and other statistics, there is no disaggregation of data of people over a certain age, such as 60. So anybody who's over 60 is put into the same category as someone who's 90 or 95. And this is a problem because in a way it obfuscates a number of different experiences of people and different facts, and in our inability to actually understand what's happening to people over certain ages. And this may have been acceptable a long time ago when people thought that 65 is the tail end of aging, but now that we are seeing more in the 90s and above, that this sort of aggregation of data and sort of the non-disaggregation of data is sort of somehow erasing different kinds of inequalities that we should be paying for. And then, as many of you will probably perhaps even worried about or see, is that there are different kinds of age cutoffs for valued social services and social roles. So an arbitrary age like 65 as being the age at which you are no longer able to work, or you must stop working, and different kinds of restrictions on what you may and cannot do. But also in medical care, we also have a number of different kinds of problems, such as, for example, older people are not included in research trials. And this was particularly the case very recently over the last 2 years, where if you wanted to do a systematic review of different kinds of treatments for COVID, you would find that the majority of the populations that were in research trials were not older people, and yet the patients that required the treatment were older people. And so we have to do a lot of work there trying to figure out whether they're relevant or accurate. But then there's also, as many of you bioethicists probably know, is that there's lots of issues around consent and proxy power and long-term, and then consent with dementia, et cetera. But the things that I want to also raise is a number of other kinds of problems that we find outside of the healthcare and health domain, such as huge amounts of physical violence and mental violence experienced by older people around the world, in many in developing countries as well, where they're living in joint households and there is a great amount of abuse that goes unreported, but when we research it, we find it. We also find a great amount of abandonment and neglect, particularly women who are older and who no longer have a husband or who are widows. They're also abandoned, their property taken away, as well as losing other kinds of access to resources, which then impacts their mental and physical health as well. And then there's some other examples, such as in humanitarian emergencies, what we find is that funders who do fund humanitarian emergencies do not fund goods and services for older people, so that in terms of chronic diseases or other kinds of aging-related diseases, the crisis packages that funders are funding do not include older people. And this actually creates a number of difficult problems, one being that some communities actually value their older people, and they find a great amount of discomfort and conflict when the sort of humanitarian agency only provides help for children, women, and others who are severely impaired, but not for the chronic conditions that older people find. So there's a huge variety of different kinds of what we would consider to be unfair circumstances or injustices on the face of it that older people face around the world, both at a structural level in terms of data and services, but also at an individual level in terms of the kinds of things that they experience and that they need. So the question for me and for others really is, on what standard do we use to be able to assess the justice of the experience that older people in countries and across countries are experiencing? And my particular takeoff has been, in my work in social justice philosophy and health, is that I am an advocate of the capabilities approach, which has for a long time from the beginning made an argument that the way that we should be thinking about a just society is that we should be focusing on the well-being of people and individuals in particular, and that the way that we conceptualize and think about and measure and implement policies is to focus on well-being in terms of their capabilities. And that is that well-being is best conceptualized not in terms of their resource holdings, their income, their wealth, their commodities, nor in their mental feelings of happiness or preference satisfaction, nor in their satisfaction of basic needs, but in terms of what did they actually able to be and do in their daily lives. Are they able to pursue the kinds of life that they value and they want to do? And so if I sort of start from there and sort of say that my standard of justice that I am sort of using in sort of thinking about older people is to think about how capable are older people to live the kind of lives that they want to live, and what are they able to be and do in their daily lives. And that the capabilities approach makes an argument that individuals have essentially a moral entitlement to this capabilities, as in a way that we sort of would say, why do people have an entitlement to well-being? It's sort of that kind of argument that we think that, based on our values of equality and the value of freedom, that we want everyone to be able to pursue their life plans. And the best way to think about that is in their sort of capabilities. So if we use that as a starting point, what I would argue is that what we find is that in many situations around the world, older people are profoundly constrained in their abilities to be and do what they value. But it's not as simple as thinking of older people as being a single category that we need to think about. I've sort of already sort of talked to you about some of the general problems that the data systems and policies might do. But once you start thinking about sort of capabilities and the idea that older people have a moral entitlement to a basic set of capabilities for a decent, flourishing life, including the capability to be healthy, then what really comes into fore is this idea about, do these capabilities exist for older people, but also what are the different kinds of inequalities that exist among older people for these kinds of basic capabilities. And this is, I think, why I showed you the basic slides in the beginning, is because when we start thinking about inequalities in life expectancies according to socioeconomic class, what that shows us is that this is not a natural cause of inequalities in terms of life expectancy, but it's actually something that social conditions have created in terms of what sort of class that people are living their life in, but what are the different kinds of factors that are impacting different socioeconomic groups and what is leading to their lower or higher life expectancy. And so it really brings into the focus the question about what are the determinants of a long life and the differences in life expectancy, and using the capabilities theory as a moral sort of ruler as a standard of justice, we can then make an argument that there is something to be done about the inequalities among these different kinds of social groups. This is particularly important, I think, in the United States, where race inequalities are very prominent, where we see that there is a very profound difference between two groups in particular, namely whites and blacks. And we see that life expectancy has been lower for blacks for generations, but more recently we can see how even access to education is not improving life expectancy. And this, I think, is once again sort of enough sort of compelling reason to think about what are the different kinds of causes of life expectancy inequalities. But if you remember, I showed you that there was this sort of slide about the different vitality scores among older people. And why I showed you that is because I think it's really important for us to appreciate that there is a huge variation among older people in terms of their health and well-being. And that vitality score is one piece of evidence that reflects that. Too often we think about all older people as being some sort of equally vulnerable. And I think that this is a great mistake, and it sort of obfuscates something, two pieces of facts that I think are worth sort of moral evaluation. One is that there is a great amount of physical and mental suffering that occurs within that group that happens at different sort of intensities based on different kinds of social circumstances. And yet our policies are not well focused and attuned to those kinds of differences. And I think this is an important thing that policies need to take advantage of, take a sort of focus on. And it's something that we also need to think about in terms of our sort of commitment to more fair sort of life course or life opportunities. The second thing that it also raises for me, and I hope for you as well, is that the great inequalities among people who are older, in terms of their quality of life, their vitality among age groups as well, also raises the question that there's a significant number of people who actually don't get to even 60. And so there is essentially a missing group of older people that should be there, that are not there because of a variety of different kinds of social circumstances that cause disease and premature mortality. This is important because for a number of us who are concerned with equity and justice and health, we often focus on people who are here and the need to make their current life situation more fair, more just, more equal. But however, I think that there is something to be said about also trying to do justice to the people who are not here, is that people who actually don't get a chance to live a long age or don't get to 65. And so there is something to be done and to think about in those for those individuals as well. So if I sort of hopefully have spent enough time there in thinking about or presenting to you the idea that we not only have to think about sort of older people in their old age in terms of how they're treated, but actually focus much more on the inequality within older people and think about what are the different kinds of causes of inequality within older people and why they are there, but also think about the missing older people and why they're not there. I want to now move on to the other part of this talk, which is this idea that social inequality is not as benign as many people present it, and even social determinants of people present it. What I mean by that is that I'm really excited and thrilled that many people now post-pandemic in the United States are talking about social determinants of health. And this is an important, I think, step for public health and for society in general to be able to acknowledge that health is not just about healthcare, but it's also not about individual choices only, but there's a significant amount of social circumstances, social conditions, not only in the present sense, but over the life course that impacts health outcomes in a person over the lifetime or in a particular crisis as well. I think that's profoundly important. What I don't see, and not enough attention, is this idea that inequality actually benefits certain groups of people, and therefore it raises certain kinds of moral and ethical obligations. So what I mean by that is that we have this idea that there is a social gradient, as I showed you, in terms of socioeconomic gradient, that there's inequalities. And one of the presumptions of many people who work in social determinants of health or social epidemiology or health equity is that if we provide different kinds of goods and services, or if we change the circumstances of the people that are worst off, or the next category, or the majority of the people at the bottom, that we're going to improve their lives. I don't think it's that simple. One of the important things about the social epidemiology, particularly some of the studies, the Whitehall studies and other studies have shown, is that health inequalities are not just reflections of material inequalities. They actually reflect psychobiological pathways, which means that health is actually, or disease in the body is influenced not just by commodities, but the way people treat each other. And this treatment of each other in terms of how we relate to each other within a hierarchical work environment, or how we relate to each other in a hierarchical society, is actually causing and distributing disease in individuals and also impacting their life expectancy. But what people also don't seem to sort of pay enough attention to is that being on top actually could be better for you, and being on top at the same time that someone's on the bottom is also potentially useful and beneficial to you. I think this is it's a much more difficult problem, that inequality is beneficial to you, not just by the fact that you have more and you're just doing more with what you have, but that your more is actually dependent on there being someone with less. And I think this raises a number of different kinds of issues. So let me give you a couple of examples by this kind of analysis that I'm getting at. So one of the arguments has been that the great amount of life expectancy that we have achieved in the United States, for example, among white people in particular, has been that there's been a great amount of social and material improvement of quality of life conditions in the United States over the last 30 to 40 years. So for example, baby boomers are given as an example of they were born at a particular time where they're very lucky that the economy was booming, the education was improving, science was improving, healthcare was improving. And all these different kinds of conditions have allowed for baby boomers in that certain generation to live really good quality of life, earn quite well, own property that has increased in value over a lifetime, get access to healthcare if they're unemployed, steady employment, etc. And this has all produced sort of great health, good health, and for them to live a long life. What has been less discussed is that that kind of social development and progress has at the same time depended on lots of different kinds of social inequalities and social hierarchies. So one crude example is that, for example, let's take Jeff Bezos, is that Jeff Bezos is doing really well in the world and his life, but it requires that a lot of workers work at minimum wage in his corporation on which he benefits from. Now, if we use that example in much more across society, then you can sort of start to see what I'm getting at is that for there to be a top, there needs to be a bottom. And therefore, the inequalities that we see in terms of life expectancy and health outcomes later in life are a lifetime of spending life at the bottom in service of people at the top. And this, I think, as you can see, there's a lot of political and economic, ideological sort of discussions to be had of that kind of analysis. But I want to at least make that sort of put this on the table for us to really appreciate that it's not just simply the redistribution of goods from bottom, top to the bottom, but there is something about the relationality of people, top, middle, and bottom, that impacts health inequalities as well as life expectancy. And this raises the question about what rights and obligations do people at different levels in that hierarchy, even in old age, have towards each other. So if somebody is 65 and is sort of doing really well in life, what do they owe the people that are in their same age group, but from different socioeconomic classes as well, that are not so good in old age as well? So that's one sort of argument about the relationality of within age cohorts that is important to think about. And it really comes into play at the end of life, where you see where your life course has brought you and sort of thinking about what do we owe each other if we both ended up here because of our interrelationships, and what does this mean for what we do for the future. The second part of this argument that I want to lay out is about global justice. And so taking that Jeff Bezos example is that not only is sort of someone like that, or that group of people that are doing really well at the top, not only have they benefited from a social system within their own country, they've also benefited from the way that their country has dealt with the world itself over the last 30 to 40 years. And so we can think about what sort of ways in which that Americans or Brits have really enjoyed good quality of life over the last 3-4 decades that allows them to live longer and to live better quality of life at their older age because of the way that their countries have related to other countries and other people in the world. And what does that say about our interrelationality between countries, but also between age groups across countries? So what do older people in the UK, for example, owe older people in other countries if their long life and well-being and quality of life has been somehow contributed to through by other people? So this was a theoretical argument that I was thinking about until very recently, when I found some more empirical evidence to support something like this. Most recently, there's an article by Professor Bambra in the United Kingdom talking about how the UK welfare state, most people think about the UK welfare state as being a great reflection of egalitarianism. And so post-World War, you have a deal that's made as a way to sort of reflect egalitarian ethos, the establishment of various kinds of social programs for all people, including the National Health Service, which is sort of a way to thank people who are coming back from war for providing sort of their life and risking their life, and therefore sort of, returning the favor by providing them healthcare and their families healthcare. And this is sort of the foundation of the NHS, is that everybody has access to healthcare, and this is egalitarian ethos. Amartya Sen also gives a very good example of, during World War II, that there is a great commitment to egalitarianism and social cohesion through the idea of using ration cards. That is, that in order to avoid inequalities in nutrition and other kinds of health problems, the government issues ration cards so that all the food that's available in the country is distributed according to basic needs, or needs so that there is no malnutrition. And this, Sen points out, avoided severe malnutrition among the poor and also children. And this actually produced one of the greatest sort of healthiest populations in England in history, and also avoided a great amount of stunting and educational problems that other countries like Netherlands and Germany showed. What Bambra shows more recently is that the great amount of social provision that the UK was able to provide was in fact funded by a number of resources, particularly taxes, from its colonies in India. So it turns out that the UK, or not the UK, but England and all these other countries, nations at that time, and England in particular, was drawing enormously on the resources of its colonies, India in particular, to the point that it was in sort of 1.8 billion pounds in debt to India prior to World War II or something. And then afterwards, there were various different kinds of ways in which that debt was somehow erased and never paid back. And so Bambra argues that there's a great amount of work to be done about understanding the resources that a nation state like England actually drew on, and sort of simply to think about it as being a domestic issue erases a great amount of history, but also implications of how the welfare state developed in the UK based on the resources that it came through the colonies. And I think that that raises this question about sort of the high quality of life post-World War II, about who actually funded it and how did they fund it, and what sort of obligations do they have to those people now that they are benefiting from all those foundations. I think there's also similar kinds of stories to be told in the United States about where does the health and longevity of the current baby boomers and others come from? Is it purely a domestic story, or is there an international story to be had? And therefore, if there is something to be said about how globalization, and before what we thought about globalization, what are the different kinds of resources, talents of different kinds that were brought into the US in order to benefit its population, what sort of obligations do we have? That then sort of leads me to that point about saying, what do older people in the United States now owe to older people in other countries, particularly those older people that are missing as a result of not being able to get to old age? So with that, I want to sort of just go through what I've just said in this talk. It's fairly simple. There's only 3 points that I wanted to make. First is that the way that I've been thinking about justice in older people is by using the standard, or the moral ruler of the capabilities approach. There's different ways, and different people have been using it. So some people are Rawlsians, some people are utilitarian, some people might be basic needs, or some people might be using the bioethics principle. I've been arguing that we should be using the capabilities approach as the kind of ruler against which we assess justice and fairness of quality of life of older people. And the kind of impetus that has is that the WHO in 2015, in their World Report on Aging or Healthy Aging, actually uses the capabilities approach in defining healthy aging. So what it does is that it sort of departs from different models that are currently operating in gerontology and geriatrics, sort of away from active aging and healthy aging to using this sort of idea of functional abilities. So it sort of uses this idea that there's this intrinsic capacity and there's an extrinsic sort of environment, and those combined create a functional ability. And we should be sort of engendering an environment in which people have good functional abilities to pursue the kinds of lives that they had. So if we use that as sort of both the empirical and also the normative standard, it really does present us with lots of different kinds of questions about inequalities that older people face in terms of each other, in terms of what's going on with older people. And so for us to pay much closer attention to in sort of intra older people inequalities. But also I wanted to raise this sort of second question, that when you look over the life course and you look at sort of the quality of life of older people, it's sort of, we need to also think about sort of the responsibility that older people of one socioeconomic group have to the people below, because their sort of better quality of life may actually be at the cost of the people below. And then also thinking about global justice and global inequalities in older people, and thinking about how did certain countries come to have such good quality of life, particularly long life expectancy, and whether there has been sort of a use of different kinds of resources that they have taken from other countries that require some sort of moral reciprocity in thinking about older people. All of this is really just a very, very thin slice of a much larger set of issues. So in thinking about the future, what we have is that in most of the world, in most LMICs, we have very little capacity for governments and institutions to address the growing population of older people, and we know that. And even in rich countries, what we see is withdrawal of the state from different kinds of social services, and we have a sort of entry of the private sector into different kinds of healthcare, but also the quality of life services. So what we're going to see is even more widening inequalities among older people. And I think this is going to be one of the most important things that we need to address. The pandemic for me is not a disconnect from a story, but it's actually simply an acute illustration of something that is going on in the background. This sort of great inequalities, not only between older and younger people, but that actually within older people, there are some people that are more vulnerable than others. And this pandemic has really illustrated that those people who died are actually the most vulnerable, whether they be the racialized minority, the poor, the people with poor health who don't have access to healthcare, et cetera. And we have yet to actually understand the full extent of their mortality. So currently official statistics say 5 million people. The Economist argues that it's more closer to 25 million. And most of those deaths are going to be in low and middle income countries where data is not really fully reliable and age stratified data is not available. But if we are to take the existing mortality from the US and the UK and other countries as illustrative, we can expect that a significant amount of mortality in low and middle income countries was older people. And I think that there is great injustice in that they are in fact illustrating the great neglect of older people and their life course trajectories and the great amount of suffering that they have had. And as I said, it's not all older people that died, it's some older people that died that potentially had very unfair lives that we owe some sort of recompense to. So with that, I hope to open up to questions, and please do ask any questions regarding the slides, or if you sort of have any questions about said. So I apologize, I'm used to speaking to a room full of people and I've just been staring at myself on the screen. So I hope some of that made sense, but I look forward to your questions. And also if you have any comments, please go ahead, say, it's a comment, it doesn't have to be a question as well. Thank you.
Thanks very much, Sridhar. While we're waiting for a question or two to come in, why don't I take prerogative here and offer maybe one or two Um, so I thought your comment about there being diversity and inequity within the category of older people was very important and helpful in this context, and also about the relational responsibilities of different people within the category. Um, I guess I would hoping maybe you could clarify a little bit more, or just speak a little bit more to the what you see as the key indicators of capacity to support others, maybe within the group of older people or even outside that. And it sounds like one is certainly sort of the monetary element, and you were mentioning, you know, the ability to, there's kind of socioeconomic dimensions, but also seemed like you were speaking to other functional abilities, maybe cognitive abilities. I don't know, but if you're able to, yeah, to speak a little bit to that, I think it would be quite interesting.
So do you mean what are the different kinds of interventions that we could take to reduce the inequalities among older people, among the different kinds of, say, socioeconomic groups among
Yeah,
older people?
I was just thinking more broadly about what are the capabilities or capacities of older people as a group, and how can that be leveraged internally within that group to minimize some of the disparities and inequities. Acknowledging that money is one of those capabilities, but you know, or one of
Yeah,
those.
so I think that what's really interesting, and there's some work that's actually being done. You know, the one that I know, and I apologize if some of you are on this call, and if you do work in this area, please say so. So there is people that are working on capabilities of older people, and sort of trying to identify what they value. And it's actually really interesting is that what we found is that, you know, while political philosophers might be sort of arguing over what sort of constitutes a decent, flourishing life, it turns out that different capabilities matter more and less over the life course. And so for older people, certain capabilities matter more than they ever did before. And they're not as what you and I might want to sort of argue. So one of the things that's really important is this idea of having a meaningful role. So this idea of being valued and being able to contribute and valued and role. And so it turns out that this actually has a significant impact, not only on mental health, but also on physical health as well. So if you can, rather than, so isolation is one big thing, and it's not just simply a mental health thing. It's actually if you can help individuals find purposeful roles so that they don't feel like they've become sort of excluded from social participation and meaningful social roles, this has lots of things. So that's one thing. So particularly the most vulnerable, if people can find a way not to just think of them as passive objects, but to think of them as agents who have, you know, sort of roles that they can contribute to. I think that's really important. The second thing is that it does turn out that you know, social engagement is really important. And so I think this is a different sort of thing about being able to relate to each other and sort of live together and participate. And what it turns out is that, you know, in different societies, and I think this is much more an issue with rich societies, that, you know, there has been a model that somehow, you know, you get married, you have a house, and you live with your partner and children, and they go away, and then you live in this. And so that sort of has set up people in order to become very isolated. And so this whole idea of being able to live together with people again, and not necessarily in nursing homes, right? So in a different ways of thinking about it. So those are two things that I know about, that sort of really, you know, both things that older people value, but also could, in a way, deal in sort of help each other in that kind of way of reducing sort of well-being inequalities. I think there's a lot more. Older people also want to practice religion. This is one of the things that becomes really important to them, and so it's a question of stuff. So I'm sure people will have more questions, but I hope that that sort of is
Yeah,
directs at what you
absolutely.
were saying.
Yeah, if I could just pick up quickly on that last point you made about religion, it does seem like, you know, if you know, statistics show that older people tend to see religion as being more important in their lives or something, like, you know, as you know well. Yeah, I wonder whether, like, what your thoughts are on that, like whether is religion the sort of thing that can help stimulate more engagement with others in a positive direction, whether it's global engagement and support or addressing some inequities, or is there a risk of sort of insular help, insular, more insular forms of meeting one's responsibility, relational responsibility, whether that's problematic. I don't know what you think about that.
Yeah, so I haven't really honestly looked into the religion bit. I guess the what I am assuming is that it's sort of what I'm assuming it's what the man who gave birth to this idea of social capital. um I'm forgetting the name. But but he wrote this book called Amazing Grace and the role of religion in building social capital, and he argues that it actually has nothing to do with the religious edicts in the religion. It actually has everything to do with the people that you spend your time with, who have similar kinds of social values as you do. And so it's not about what the what the rules are of your religion, and it has to do with that sense of a shared sort of community, and sort of, yeah. So I think that's the pleasant place where I'd like to keep the religion thing. But I don't know what other roles that might. But like I said, we don't think about what the bad parts of being on a social hierarchy or becoming very religious does for the benefit of individuals, right? So we don't really think about whether being in the mafia is actually really good for your health, because it sort of does something for you, but we don't think about that in terms of other things as well.
Great. Let me just read out one of the questions here in the chat. So first, thanking you for your excellent talk. So curious about, in the course of your work and research, have you found any information about what older people say about their own circumstances and on this particular topic as well? So are they engaged in shaping what is just?
Yeah, I think that what's happening in a lots and lots of different places is to transform the conversation of older people away from being passive objects to being active agents in their lives. But also in the United States, older people are one of the most powerful political groups in the country, and they tend to make their voices and wishes quite heard. So definitely what we see is that in the research that's being done about healthcare and health technology assessment, what we're seeing is that older people are very clearly sort of saying, it's not just disease management that I'm interested in. There's also other things that I want as a result of this medical intervention. I want to be able to move around. I want to be able to see my family. I want to practice my religion. So if you've got two different interventions and one will allow me to do that and one won't, I would like the one that will allow me to do that. So that is kind of a way in which older people are sort of actively participating in redefining the kind of terms of reference for what good healthcare is for older people. But also in terms of what you find is many of the research in dementia care, for example, involves older people, particularly older people with dementia, and they are also contributing to this conversation. I don't think that it's enough. I think that there is still very much a kind of minimal engagement with older people, partly as a reflection of this idea of involving patients in research, but I don't think it's sort of very sort of profoundly engaged in sort of community engagement and community discussions. I think there could be more done. But if you are interested, I would recommend that you look at some of the work that Jo Coast at the University of Bristol in the UK has done, where she is sort of talking to different community, older people, to define the different domains of assessing health technologies. So they're definitely involved. So in terms of justice and fairness, I don't know if there's actually been a program that looks specifically at what older people think about justice and fairness. Thank you.
Yeah, great question. So we have a couple more here in the chat. So there's someone who says, as Asian, I think most difficult thing to do is convince older people. And culture, religion, superstitions are those, I guess, are contributors to shaping belief. nevertheless, some of the things to consider: a willingness to caretake, care planning. Yeah, so I'm not sure I can understand the question fully, but maybe there's
Yeah,
some.
so I guess I'm going to interpret that question in the way
Yeah.
that I would like. So I'm going to say that the idea is that you're sort of making a point that somehow it may be that there is not necessarily an older person is not necessarily ready to engage with the conversation about what would be good for their well-being, for example. And so their long-term, short-term well-being would benefit from different kinds of decisions, such as should they have a caretaker? What sort of forward planning should they have about their legal, financial, medical care? And they're not willing. And I think that this is a really kind of simple and nice example of the capabilities approach, which is that what you want is that you want to be able to help individuals sort of recognize and help them understand and also consider what are the different kinds of factors that are constraining their abilities to do certain things and be certain things. So for someone to not be willing to sort of talk about those things means that there's actually something that's stopping them from doing that. It's not as though they're a bad person or irrational person or unreasonable. And so that's a great opportunity to actually have a conversation and say, why is this difficult to do, and how can we help do that? And that sort of shows you also the role of the family in sort of enabling the capabilities of older people. That's the easy way that I've interpreted your question. I hope that that's the sort of right way.
I think that's right. Another question here. So asking you to maybe unpack your claim a little bit more about, being up necessitates that others be down economically. In the Jeff Bezos example, what I guess the question here is, what are the Jeff Bezoses, I guess, of the world to do in response? What are communities that have Amazon as a major employer to do? So yeah, I guess maybe thinking about the implications of the idea of
Yeah, so the
that balance.
Jeff Bezos Amazon example is, I think, sort of trying to give you an illustrative example that you have very clearly a hierarchical structure within this corporation in which sort of there's a few at the top that benefit enormously, and the majority of the people at the bottom are not enjoying good quality of life. But the idea is that the people at the top are at the top because there are people at the bottom doing what the people at the bottom are doing. And so there is a structural dependency of the top on the bottom. So what I was saying is that not only is it just a question of material inequality, that's the question, but there's also a psychobiological relationship between the people at the top and the people at the bottom and in the middle. So basically, you might have different kinds of cultural jokes, for example, right? Is that people like to laugh at someone who's just like them, but slightly worse off, right? So it makes you feel better that you are not as bad as they are. And that's sort of somehow very funny to people, is that there's great empathy, but also there's a sense of superiority and stuff. So it was that kind of example that I was showing, is that we haven't really done very much about what is it that benefits people aside from just material stuff, but actually the psychobiological benefits of feeling superior and being on top, and how does that impact you? And so there's a lot that we could sort of still be doing and thinking about in terms of social hierarchies, and how the benefits of being on the top is not just material benefits, but it's also different kinds of psychological benefits of being the one on the top. So that's what I was trying to get to on that. And so what does, someone who's, at the top being at the bottom, what do they owe? Well, firstly, I think we really do have a situation in America that most people who are at the economically top and the billionaires do think that they've actually made it because of their individual brilliance and hard work, and not necessarily about the great amount of social conditions over their lifetime that have enabled those kinds of opportunities and the social investments that are made. And so one of the questions is that, what sort of return does that those kinds of individuals give back to society as a result of that. And so we can talk about taxation, we can talk about something else, we can talk about whether philanthropy is the right way to do it or not. But I'm sort of very focused on this idea of within the age cohort, sort of thinking about people that have journeyed with you on a journey and they carried your bags all the way up. What do you owe them aside from just simply saying, thank you very much, right? So there's something about sort of thinking about what sort of reciprocity there is for that kind of journey and that kind of experience.
Well, I'm afraid we're going to have to leave the last two comments in the chat. One is about sort of how the implications for policy of like variations in the capabilities that different groups prioritize, and then the second one was about the decline in union power and implications there. So maybe we'll leave them there for now for you to consider since the time is short. And just thank you again, Dr. Venkatapuram, for joining us and offering this really interesting, stimulating, thought-provoking talk today. So thank you again, and thanks all for joining.
Thank you very much for this opportunity. I wish you all well. Thank you again.
Great, thanks.